I'm hopping on because I have like an urgent need to make sure everybody knows this. I just read a recent report that came out, honestly, maybe a week ago about a global survey unraveling hypermobile Ehlers Danlos and HSD or hypermobility spectrum. It's a pretty big article, so I have it pulled up, but I do have a lot of it in my brain because it was just really interesting to me how underdiagnosed and misunderstood it is. These patients are waiting over 2 decades to get a formal diagnosis, even though symptoms show up early on, 2 decades before they get a diagnosis, which is insane to me. It's estimated that 1 in 500 people have these conditions that are still poorly understood, misdiagnosed, all the things. When we look at the survey, it was almost 10,000 people that were interviewed and surveyed, and almost 4,000 met the criteria for HEDS or hypermobility, Ehlers Danlos, and hypermobility spectrum disorder. And then there was a confidence level of 95%. These individuals not only waited 2 decades, they also have up to 24 comorbidities, 24, as well as that formal diagnosis of HEDS or HSD. Now, some of those comorbidities, I would say most of them, there's a huge overlap there. And when we're talking about like skeletal, musculoskeletal, neurological, autonomic, it really affects every single part of the body. It doesn't isolate its symptoms to one area, even though one area may be loud enough to get somebody to go get further evaluation. But on that note, like this survey has written about, we're not diagnosing because there really isn't a formative diagnostic criterion. There's the Baton scale, and there's no genetic markers as we know of now for EDS, HEDS, and HSD. Now, it's also interesting in the demographics. Most were white, Caucasian population. Most were of middle age. There were some that were older. And this is crazy that 86 to 87% of the EDS and HSD were identified as women or assigned as women at birth. What was notable is 12% responded that they had a gender different from their sex assigned at birth. 12% is pretty noticeable. And sexual orientation was highly diverse. Large population identifying as LGBTQIA plus in that spectrum. Triggering these events, or really what I think of as like domino occurrence, for me, it was menopause and kind of around that same time of COVID. So I did have COVID twice. I was probably moderate with my symptoms, but typically what we're hearing is that there was an event, either hormonally or a viral event, that triggered the symptoms, noticeable enough to get help for them. The highest reported symptom is chronic pain, 32% to 34% in both of the HEDS and HSD populations. Joint manifestations, autonomic dysfunction were up there. And then in the middle of the symptoms, having the most percent comes in with mental health, sleep, and allergic symptoms. With chronic pain being the number one symptom, the chronic pain sites, number one area was the neck. I'm winning with all of these symptoms. Neck, then lower back, my neck, my back, shoulders. I don't know if you can hear this, but I can pop it back in. Shoulders, and then hips, knees, and fingers. So those rank the highest in regards to the areas of chronic pain. So pain management is the biggest concern here, and why I am speaking out on this, being a registered dental hygienist and also a person who owns a private therapy practice where we deal with orofacial and jaw joint pain and headaches and things like that. We have to know what we're looking at, and we have to know what we're seeing when people come in and write on those medical history forms, because we can make a difference. I'm talking to other orofacial myologists, dental professionals, and honestly, if you're a clinician, just having an open ear of what the buzz is going on with EDS. EDS is having a moment and menopause is having a moment. And those are two chronic illnesses, if you want to say that, or life changes that affect women. They affect women 87% in this population. Another thing to note is there is anesthesia complications, local anesthesia and general anesthesia. They're short in effect and insufficient pain control. Now, when we're talking about pain control, what has worked and what hasn't worked, cannabis, cannabinoids, and THC is amongst the highest rated that works, and I vouch for that too. And then other symptoms are mainly orthopedic symptoms, joint subluxations and dislocations, fractures, slipped ribs, which I, growing up, remember just laying myself out on the floor in extreme pain, thinking to myself, does anybody else have where it feels like a rib is puncturing your lung? So that's pretty common with the HEDS population. For neurological, migraine was the most frequently reported neurological diagnoses. I've started on a beta blocker, and that has helped take my migraines down. But I typically was getting them once or twice a week where it was debilitating, where I would have to, I hate taking the medication for it because it's like, do I choose to feel like crap the rest of the day and be out of it? Or do I choose to have a knife stabbing me in my head behind my eye? So migraines, to note, and that's something we deal with in our practice, and those of you who do orofacial myology or do anything with the head and the neck muscles. And then after migraines for neurological disorders comes in second as scoliosis. Third, Raynaud's. Raynaud's is when you start to not feel your fingertips or you get frequent cold hands. Mine looked like when I would go for a run in the winter, that's when I noticed it, is my fingertips would turn bright red and my hands would turn white. It hasn't happened that much to me, but it's typically when it's winter and I'm moving blood and circulating blood away from away from I'm circulating blood more to my heart. My body wants to circulate my blood more to my heart because I was going for a run. And so it's taking blood away. So that's also a symptom of EDS, HEDS, and HSD. All right, next, autonomic disorders, POTS being number one, postural orthostatic tachycardia syndrome. So when you stand up, your blood doesn't know how, your heart doesn't know, and your autonomic nervous system doesn't know how to balance that out. And so your heart starts being tachycardic or trying to pump more blood all around you. Usually it's about 30 beats per minute is where they make that diagnostic criteria. It's important to see a cardiologist so they can do some further evaluation on you. But POTS was number one, general dysautonomia, orthostatic type hypertension, number three. And then the symptoms autonomically are fatigue, dizziness, brain fog, and heart palpitations, the top three. GI disorders, IBS and GERD, which we often see in our practices. Pretty much most of the adults have some type of GERD, reflux, and or constipation is number three, and dysmotility. All right, cardiopulmonary disorders coming in at one is mitral valve defect, which my mom has. And you'll notice, so look for some of these symptoms co-occurring with immediate family members. So moms, dads, brothers, sisters, and then other arrhythmias, and then supraventricular tachycardia is number three. Endocrinology disorders is hypothyroidism, number one, osteopenia, number two, which my mom has, and three, Hashimoto's disease. And hematological disorders, pernicious anemia, deep vein thrombosis, and pulmonary embolism. Those are the top three hematological disorders. There's also some concerns in reproductive health. So it's important that's why I am discussing this, because it's important to get that diagnosis. A lot of people say, why would I want to get it? But it's important to have, especially this is mostly women. So if you plan on reproducing, you want to have some counseling before that. I did not. I had my kids a long time ago. And there was lots of complications and a lot of trauma involved in and around the pregnancy because, of course, they didn't know what was going on with me. And so you're just managed differently when you should be managed like you have HEDS, EDS, or HSD. Urological, urinary disorders, more prevalent with UTIs. It was off the charts with UTIs, frequent UTIs, and then bladder things. So pelvic floor therapists, PTs that are involving themselves in pelvic floor. I think most of you guys know about HEDS. So props to you for knowing about this and educating. So this isn't something that we're just automatically going to learn. Those of us who deal with patient population that has a profound diagnosis with and within EDS, HEDS, and HSD. And then reproductive symptoms on menstruation and pregnancy, pelvic pain. So think of endometriosis, irregular periods, pain during sex are the three top reported symptoms. And let's see, nothing else really to note there. And then dermatological, so I don't know, it's kind of gone now, but I started getting just breaking out hives if I have anything that rests anywhere for a long period of time. When I go swimming and I rest my arms against the cool deck, it just blows up. I don't know if it's a combination of two, but yeah, atopic dermatitis. And then I do have to go get a workup to see and rule out MCAS, which is mast cell activation syndrome, which is a really high co-occurring comorbidity in this population. And other dermatological considerations, soft velvety skin is very high up there, abnormally stretchy skin. So being able to really stretch out your skin. There's other places that are a little more stretchy, and soft skin at unexplained stretch marks. I have a lot of those. Those are the top three. And then allergies, asthma. These are allergy and immune related, and MCAS. Those are the top three in the allergy and asthma category. And then ocular astigmatism, hyperopia. Those are the top three. And some symptoms, ocular symptoms, light sensitivity, visual disturbances, and dry eyes. Okay, drum roll. Dental disorders. Dental people, we need to know about this. We need to know about this population, and we need to know more, educate more, because we're probably going to see a patient in our chair more frequently than the GP or the PCP. So TMD, as well as enamel defects and early onset periodontitis. So if you have a teenager in the chair, a 20-year-old in the chair, and their OH, their oral hygiene looks good, the risk factors are low, and there's periodontitis present, and there's really nothing else to suggest this is why it's happening, talk to this patient and encourage them to find more out about EDS. Ehlers Danlos website is a great organization to send them over to. There's lots of things to read. And then you can encourage a referral back to their primary care to organize treatment and organize referrals. And unfortunately, it may not happen right away. And based on this survey, they may not be taken seriously, and they may have a delay in onset of diagnosis. But it's our job to educate them about what we know and allow them to have that information and further investigate what they can do about obtaining this to help them. And then when we also discuss the other part of our body's mental health and sleep, high prevalence of anxiety, rightfully so, because there's a lot of health issues going on, depression and PTSD, rightfully so, because there's probably, like my journey is, having a lot of things that have happened to me that could have been managed better if I would have known this back in the day. And then secondary to that is OSA, or obstructive sleep apnea, which we deal with as myofunctional therapists, and then restless leg syndrome and insomnia. I had horrible growing pains. That's usually one of the first things that shows up when I was a child, to my daughter. And so if you're a parent and you feel like you might have HEDS, EDS, or HSD, and you have a child that complains of growing pains, it's worth discussing it with their pediatrician. Okay, now more in the dental symptoms, the jaw pain, dental crowding, subluxation or dislocation of the TMJ. So if you're seeing a patient that can open and hyperextend that jaw. And then there's other markers. Yes, let's talk to them about seeing their PCP and getting that proper referral and organizing a treatment plan for them. Tooth sensitivity without cause, which I see very commonly in the population that we're treating, a lot of crossover here. And then high narrow palate and frequent cavities. Now, there's a high frequency of neurodivergency, ADHD, and autism within this population as well. And it's just interesting. There's something that's pulling all of this together. And so it makes this survey is really to say that we need to ask more questions. That is not just connective tissue and collagen. Most likely it's probably a combination of that and neurological basis or foundation. That's why we're seeing it affect every single symptom. There's what we call a multi-morbidity in HEDS, where there is so many other co-occurring comorbidities: POTS, GERD, constipation, TMJD, insomnia, and so on and so forth. So I wanted to discuss this because, my journey and being diagnosed and being at 45, I'm seeing so many patients in our practice that have a lot of crossover, and I wish I knew more, but there just isn't more out there for us to make a definitive diagnosis or that referral, because there's not a lot of people that have the awareness, enough education that they've self-educated and self-taught themselves, because honestly, they're not teaching it to us in school collectively. And if they did, it was, oh, we were never going to see a EDS patient. You're never going to see one. Well, we need to catch up with what we're seeing and have a better discussion and have a better definitive diagnoses criterion for this population. And then as practitioners, I'm speaking from a patient and practitioner standpoint, from a practitioner standpoint, be aware of these other comorbidities in regards to what your specialty is, and just know enough to discuss with your patients. Hey, I know somewhat about this, and I think it's worth it to go to the EDS website and see if anything resonates with you, and then have a discussion with your primary care, or start to network and see who else is treating patients with comorbidities that are similar to EDS that don't have a diagnosis. And you guys could probably do a lot together. I just met with a PCP here that's local here to me in Glendale, Arizona, and so there's just a few of us that have beyond surface level awareness of what we can do to help support this population further, get more education out there, get more diagnoses. So we aren't seeing the quality of life is horrible because you're going decades without getting a diagnosis. And then you start to feel like you're crazy. And then on top of that, if pain's the biggest thing that we're trying to manage, it's even worse for our quality of life. So hope you learned something from this. Like and share, please. And if you have any questions, let me know. Thanks, guys. Thanks for watching. Peace.